in this panel, I'm really excited to bring together 3 fantastic speakers and 3 completely different approaches. And this time we're going to be looking a little bit more at how digital approaches can really support and accelerate both awareness, advocacy, but also the research itself, and how that collaboration, that symbiotic relationship really between science and arts can really help to reach those all-important elimination goals, sustainable development goals, and so forth. So I'd like everyone to join me in welcoming our 3 speakers for this panel. It's our great pleasure to welcome today. We've got James Vaughan. Hi, James.
Hi there.
Hi, James. You are CEO and founder of Ndemic Creations, a gaming company. We've also got Francesca Piffer. Francesca, hello.
Hello. Hello, everyone.
Hiya. You are a project manager and you work with the Digital Diagnostics for Africa Network that's based at Imperial College London. And we're also joined today, it's a great pleasure to have you, Dr. Alexandra Cossio. Hi, Alexandra. Hello. Alexandra, you're tuning in from Colombia and you are coordinator of clinical investigations at the Centro Internacional de Entrenamiento e Investigaciones Medicas, also known as CIDEIM, CIDEIM. So welcome to the 3 of you. So first and foremost, and that's, kind of the theme that has been going through our whole festival, we can't ignore the massive shock that the COVID-19 pandemic has been, and that's perhaps where we'd like to start this session, thinking and talking about pandemics and how this is one concept that, of course, is of immense, has just immense weight, really, and has gripped our whole attention for the last 12 months. But even before that has been a notion that's always, I think we sort of have a love-hate relationship with this notion of the pandemic and of the kind of all-encompassing disease. And that's inspired a lot of creative work, whether it be disaster movies, a lot of kind of horror or fiction that's really uses this notion of the pandemic, of the disease that can wipe out mankind. And James, you've said many years ago, you kind of had the idea of putting a pandemic into a game, and the aim of which was to cultivate a disease of such power that you would eventually wipe out the human race. So
not very nice for
not very nice, particularly after 12 months of an actual pandemic, but it's okay, we forgive you. Anyway, I'm just being tongue-in-cheek, but we felt it was really interesting, actually, how out of that concept, I suppose right at the beginning, you were probably just trying to make a really great game. And this took on a life of its own. It's now been downloaded more than 1 million times. And I suppose particularly at a time when there is an actual pandemic ongoing, perhaps that comes with a sense of responsibility as well. And actually quite a great vantage position to reach out to very wide audiences. So James, I'd like to hand over to you first and foremost, and perhaps hear a little bit more about Ndemic, your company, but also about your game, Plague Inc., and how can we leverage video games and digital platforms to help global health and infectious disease awareness, and perhaps also, reach out to all those all-important audiences out there. So James, I'll hand over to you, and we look forward to hearing a bit more about your work and your very exciting projects.
Okay, cool. Hopefully bring up the slides. Shout wildly if people can't see them. Yes, so I make a number of games which are based on real-world issues, and the most well-known of them is Plague Inc., which, as Marianne mentioned, sees players trying to infect everybody in the world with a deadly disease. I made the game originally back in 2011. I never thought I'd see what I'd made as a game to play out in reality, but we'll talk about that a bit more in a moment. I'll just give a quick run through of what the game looks like for people who aren't familiar with the game. So you start off by selecting a disease type, and then our simulation will almost look at the world as a petri dish, and it will let players see how this disease spreads around the world via boats, via planes, the consequences of shutting down airports, a lot of themes which now everybody is very familiar with, but at the time seemed like quite a more novel thing for people to experience through a game. So they'll release this plague, and the player will mutate the disease and evolve it in certain ways. As it picks up new symptoms, it gains new transmission methods, it gains antibiotic resistance, all these different ways that they can tweak and adjust the game. A huge number of people play Plague Inc. We've got over 160 million players now. And the game has been at the top of the charts worldwide ever since it launched almost 9 years ago now. It's a ridiculous number. It's hard for me to get my head around that even now, but typically we have around 50 to 60,000 people get the game every day. So originally, I made Plague Inc. as a hobby. I was a management consultant. I wanted to do something a bit different. I didn't set out to make an educational game or anything like that. I just wanted to prove to myself that I could create something. So you'll see on this slide, I've got I first of all tried modeling it in Microsoft Excel using some rather complicated formula to see if I could actually get a simulation model running. And then over the course of a year of working evenings and weekends and stuff, I was able to get it into something that I could release initially on mobile phones, and then since then it's expanded to PCs and consoles as well. And now, Plague Inc. is one of the top 5 most popular paid mobile games in the world. And I've even been able to do slightly more fun things like making a board game version of the game, which again sort of looks at how would that disease spread if you were playing it on a tabletop with friends instead. And I said I didn't set out to make an educational game, but it turned out that by accident, I made a game which can inform people on these sort of serious health issues. And I was invited to the CDC, Centre for Disease Control in the US, and you can see a quote from Dr. Ali Khan there saying that Plague Inc. creates a compelling world that engages the public on serious health topics. I never set out to do that, but it just so happened that if you base a game on a real world subject and you do a lot of research and you try and really align it to what's going on in the real world, it can trigger people's thinking. It can promote thought about topics that players might not think about otherwise. It can introduce topics and concepts. And we've actually found that Plague Inc.'s been very effective at that. It gets used quite a lot in schools. The game's now been out for long enough that I've had people get in touch saying, hey, Plague Inc.'s the reason why I became a doctor. And it's crazy to me that it's been out for that long now. Or Plague Inc.'s the reason why they went into studying infectious diseases. It's really... I'm very proud of the effect that Plague Inc. has had in sparking an interest in infectious disease in people who might not have otherwise thought about it. And over the lifetime of the game, we have seen real world diseases sometimes have an impact on how many people are getting the game. And the first time we really saw this was with Ebola back in 2015, when we worked with our community to do a sort of a fundraising for charities around the world under the sort of the theme of Ebola is not a game. And since then, we've seen if there's a particularly bad flu season in, say, Japan, we would see the game go up up the charts and be more popular. And what we've seen again and again is that people disease is a very universal. I mean, and obviously it seems very obvious saying it now in a post-COVID world, but disease has always been a very universal sort of subject for people to engage in, and so the game has been popular all around the world. And when disease is proving is concerning people turn to Plague Inc. because they want to understand a bit more about it. Plague Inc. gives them almost a safe place where they can experiment and interact with the topics and subjects of infectious disease without sort of exposing themselves or needing to feel like they need to go to a library and learn stuff. It lets them learn through playing, which can be a phenomenally powerful way to interact with the content. I would never say that Plague Inc. is there to teach these concepts, but it can introduce concepts and it can reinforce concepts that people have already learned elsewhere. The game is not a scientifically accurate simulation. We've had to adjust the gameplay to make sure it's fun and accessible first and foremost. So there are certain key things that the game doesn't reflect accurately. One of the most obvious ones, which is we actually have the world map is flat in our game, so you can't actually travel between America and Asia, for instance. So, and yet these things don't matter. The core truth of how a disease can spread is captured perfectly by the game. And then, so this has all happened, and we've been sort of supporting the game for quite a long time. But then suddenly, when COVID first became an issue in China, we saw a huge surge of interest in Plague Inc. and far greater than we ever saw with Ebola or anything else, because suddenly this was impacting everybody all over the world. It was a deeply scary and worrying subject, and people were wanting to try and understand more about it. And Plague Inc. was an easy way for people to sort of just understand it, to learn a bit more about it. So we saw a huge number of people getting the game, and it was a very difficult sort of time for us as a studio, because we like our games to do well because they're great games, not because there's a serious public health crisis going on. And we needed to sort of try and work out how we should respond to all this interest, because on one, I mean, it was great seeing that the game was giving people reassurance and helping people understand the importance of washing hands and stuff, but we wanted to do more than that. So actually we worked with the World Health Organization and with CEPI, a vaccine organization, to make donations to support the fast response towards COVID. But we wanted to go further than that still. The game, as it was when COVID launched, was always about being the bad guy. You are the disease trying to infect the world, and in a COVID world that didn't necessarily feel right. And what we kept on coming up in conversations when we were talking with medical experts and doctors around the world was, hey, have you thought about flipping it on its head and making a version of Plague Inc. where you're trying to save the world instead, and we can teach people more of the concepts that have come up in COVID. And I'd always wanted to do something like this, but we'd never really got round to doing it before. And so this was the prompt for us to say, right, we're going to make Plague Inc. the cure and flip the whole game on its head and let players understand and interact with all the complexities around stopping a disease. Because it's very easy to think, oh, there are very simple things that should have been done and it would all have been fine. And actually, the world is very rarely black and white. It's normally a very complex shade of grey with lots of difficult compromises and decisions that need to be made. And I wanted to try and help people understand some of those decisions. So we created Plague Inc. the Cure inside the base Plague Inc. game, and we said we're going to give it away. We're going to give Plague Inc. the Cure away for free for as long as COVID and until COVID is under control. So this sort of is a free expansion for the game, and it lets players send investigation teams around the world trying to understand where disease is coming in. It lets people explore different response mechanisms. How impactful is face masks early on? When should you invest in contact tracing? It really emphasizes the importance of vaccine research, and something which is now very apparent, but when the cure launched last year, a lot of people weren't thinking about so much, was it emphasizes how important it is to start manufacturing the vaccine before it's actually gone through all the approval processes. So we kind of let players ignore the whole vaccine manufacturing concept until the vaccine's finished development and is fully tested, and then they have to wait a huge amount of time for the vaccine to be manufactured. So we're encouraging players to think, actually, you know what, let's put some supply chain preparations in place. Let's start manufacturing the vaccines, even if they're not quite ready yet, just so that we've got them there when we need them. And now we're seeing all the impacts of that. We model a lot of the we model the economic impacts of closing down borders and lockdowns, and how that can cause non-compliance if you don't provide enough economic support. And so players often start off the game thinking, oh, it's easy, I'll just shut down all the airports and ports everywhere and then I'll be able to deal with it fine. But actually, people don't comply with the orders, and if you haven't got people's buy-in to the actions you're taking, if you haven't got global cooperation, all of these things mean that your actions are not as effective as you might otherwise want. And yes, at the end of Plaguing the Cure, you're able to get the vaccine out. If you can get it manufactured and stuff, then you're able to eradicate the disease from the world. Now, again, a departure from reality potentially, but it still helps people understand the consequences of that vaccine manufacturing angle. So that's how Plaguing the Cure works, really. We're doing a number of things with the World Health Organization at the moment. We've had a number of their experts play the game, and they're building it into a campaign to help inform people. There's a huge potential for games like Plaguing to reach out to people who might not otherwise be interested or aware of the subject matter that you're communicating. And yeah, as I said before, Plaguing educates people by accident. It wasn't intentional, but it's something I'm immensely proud of, and we're doing everything we can to support it these days. So that's my brief rundown of it all. Marianne, I don't know if there's you want to ask me about it, or if I hand over to one of the other guys now.
Well, first of all, thank you very much. You didn't set out to revolutionize everything, but it happened, and it's really incredible that from such a, what maybe at the time you thought was just kind of an exciting but small scale project, you've now got these collaborations with CEPI, CDC, of course, WHO, and given the circumstances and given obviously how much thought has been put into not just the plague but also the cure, it's a very likely scenario that you are going to see a coalescence of more and more stakeholders, whether it be governments or other health agencies, really embracing what you've created. So I suppose in a way with this comes great responsibility for yourself. And I'm just curious to know, how do you feel about that? I mean, I suppose you're in a way being brought into the public health, global health kind of sphere. And as you said, you just wanted to create a great game. So how do you feel about this responsibility?
I think for me, it's always been, we've been very lucky to have access to experts in the field who can validate our thinking and correct. If I've got a plan for something, they can say, oh, wait a minute, maybe tweak this or change this. So being able to kind of sense check a lot of what we're doing with proper experts who actually know about it, rather than me who's just doing it as a sort of without having all that knowledge behind me, is really helpful. Certainly with COVID in particular, it did feel like there's a huge weight to get it right, and certainly not to sort of give incorrect information about stuff like vaccine approval processes or something. So really relying on experts was very potent and powerful here. But I think the other thing is that I think we don't claim to be scientifically accurate. We have always been very open that it is a game first and foremost. It's an accessible game, and people will learn as they go. And it helps people understand what they should take away from it and what they can't take away from it. And I think that's very important with educational games in general, is that it can be very tempting to cram 100% of all the education you possibly can into a game. But all too often, that turns the educational game into something very heavy and hard to get into, and people don't engage with it at all. So it's always, personally, I think it's always better to communicate sort of half of the educational value well, rather than try to give them all of it and it fails to communicate.
And that's really interesting you mentioned that, because that's kind of where the conversation started early this morning about WHO was involved. In fact, we were just talking about how has COVID changed the way we communicate and what really needs to happen. And a lot of scientists, and of course that's normal, will want to present their science with the full range of detail and, make it, of course, with the right assumptions in the right context and a huge amount of detail. And that's not always necessarily what journalists, let alone the public, really want or need, and then kind of the whole concept gets thrown away. So you're right, packaging it.
I always give the example of the London tube map and how the geographically accurate tube map, people couldn't really understand where they were trying to navigate. So we now have this fictional tube map, which actually helps people understand the core truth and get around better, even though it's actually not geographically accurate. It seems bizarre that a non-geographically accurate one helps people better, but it does. And I think that's the case with educational games as well.
Yeah, that's really interesting. And in fact, right here in the UK, we're both speaking from the UK, a member, quite a senior politician, has said that the film Contagion has been very useful in making some of the public health policies that we've experienced within the COVID-19 pandemic. So I suppose my last question to you, James, would be, do you think that in future you're actually going to see policymakers and governments, knowing that your game is just a game, but do you think they will then use that kind of role play or simulation modeling, even kind of a war game, to inform their own policies?
I think accessible simulations, as opposed to the very complex, pure scientific models, the accessible simulations have a definite role to play here. Because I think a key example with disease spread is the concept of exponential growth. Intellectually, you can think you understand exponential growth, but until you actually see those infection numbers climbing each day, climbing, I think it's very hard to emotionally grasp what that concept of exponential growth. So I think that's one thing that plaguing does very well, is it shows that exponential rise of infected. And I think that, everyone's kind of seen it now with COVID, but I think that anything which just helps reinforce some of those concepts is good. Is plaguing the right thing for policymakers to use? That's not my decision to say, but I certainly think that accessible simulations, which maybe don't get everything right, but they reinforce certain concepts, is definitely very, very, very important.
Well, fantastic. And Liz King here, one of our attendees in the chat, has Liz King is a parasitologist, and she said, plaguing is one of my favorite games. Love that you have these collaborations going on now and helping with science communication. So James, thank you very much. This was definitely a great example of the creative industries really helping and facilitating global health aims and goals. We're all going to obviously watch this space, and we can't wait to see what you do next. I know that you've got to go as well, so we're really grateful you were able to share all this with us, and we definitely hope to keep in touch. And
if anyone in the audience, if people think of ways that we could collaborate around it, we're always keen to. We're a very small team, so we're limited in what we can do, but we're always keen to find ways to support and reinforce sort of educating our players about sort of infectious diseases. So feel free to get in touch.
And the neglected tropical disease community is really great at partnering. That's what it's all about, the collaborations, WHO all the way to grassroots movements. So I'm sure there'll be lots of people who've heard that call for partnerships loud and clear and we will be in touch. So thank you very, very much.
Cool. Take care, everyone. So I can't stay. Bye.
Yeah, no worries. Thank you, James. Take care. And I think James's kind of introduction really is energizing, has really shown us how creative approaches, and particularly what James mentioned in terms of simplifying the scientific concepts, the processes, can actually be extremely beneficial to not just sharing and communicating the science, but really fostering and accelerating some of those partnerships and what is needed, sometimes in very radical terms of rethinking entire networks. And I think that leads us very nicely to our next speaker, Dr. Francesca Piffer. Francesca, you are, as I said earlier on, with the Digital Diagnostics for Africa Network based at Imperial College. And this network is in a very ambitious and innovative way, kind of looking to rethink the whole approach to diagnostics, particularly of tropical diseases and neglected diseases across the African continent. And so we're really thrilled about your project. It's hugely exciting. It involves a lot of different partners and organizations across several continents. So we're very excited. What brings us kind of here today in a creative conference is comes down really to how you've visualized a very simple image, perhaps simple on the surface, but really how you've tried to simplify a very complex problem, a huge challenge, into this very streamlined concept of innovation in diagnostic, but also a lab on a chip. How do you represent that, and how do you integrate all those very complicated issues and partnerships? So, Francesca, sorry, I'm very excited about your project, so I am talking a lot about it, but I'll hand over to you now, and look forward to hearing more about this.
Thank you. Can you see the first slide?
At the moment, yes, that's
Fantastic.
Thank you.
So yeah, as you said, Marianne, it's very important to try to make science more communicable, also because you need to liaise with the ecosystem around the project to make it progressing. So the project I'm presenting is the Digital Diagnostic for Africa Network. And I'm here today representing this whole network that is international and interdisciplinary community of experts developing an innovative digital diagnostic approach to tackle diseases, in particular infectious diseases like malaria, and that primarily affect the African continent. The network comprises of researchers and from different fields and academic institutions, and representative of not-for-profit and commercial organizations from the UK and Africa. Just to name a few, we have engineer, molecular biologist, malaria epidemiologist and control expert, parasitologist, hematologist, mathematical modelers, expert in health system and in health economics, in implementation research and human behavior interface, patient and public involvement. And then we have industry representative like PATH and commercial sector, as well like GlaxoSmithKline. Is just to name a few. In fact, we are basically 60 members, around 60 members from 15 partner organizations. And we are based in 11 different countries between UK and Africa mainly, but also Europe and America. The Digital Diagnostics was set up in March 2020. Was funded by the UKRI Global Challenge Research Fund for developing innovation and for development in Africa through digital health. And in the first year, we have worked on assembling the network, bringing together all the different experts, and I've mentioned earlier, and all completely remotely. And we have been working on co-developing an approach and framework to implement a digital diagnostic platform called LaceSwing, and which is developed at Imperial College by a group of engineers who are part of the network, and is able to detect all the malaria pathogens in few minutes, including also COVID-19, and the researchers are working on integrate dengue as well. And unfortunately, this was we are in the first year grant, which will end at the end of April. And as you may know, unfortunately, this was the sad news from last week. We won't be applying to the stage 2 because of the funding cuts the government did, and so we are looking for other funding stream, because we really, and I'm sure we will find others funding, because to make the project progressing, because the technology is very promising. And so, as I said, in the first year we have worked on the roadmap, which is the main output, is nearly finished, completed, and it set out the vision for the transformative potential of digital diagnostic for Africa, and described the journey for the development and implementation locally and at scale in Africa. And while writing the roadmap, we have also been awarded some further funding from Imperial, aimed at supporting evidence-based policymaking. And we have decided to partner with a talented designer, Jin Zhang, to produce 5 impactful figures and infographics to complement the roadmap to highlight specific key messages around digital diagnostics for Africa and key points of our implementation strategy. The images will be used to reach out key stakeholders at funding organizations such as WHO, Global Fund, Gates Foundation, President Malaria Initiative, UNICEF, and others. And the one I want to show you today is our, okay, I need to, sorry, this was unexpected. Bear with me until the end. Yeah, sorry, this one. So the one I want to show you today is the one that we think summarizes the whole concept and the potential of digital diagnostics. And as you can see, as you might know, conventional diagnostic laboratories require costly infrastructure, such as uninterrupted power supplies or clean water, supply chains, trained personnel, quality control. And it is currently unrealistic to establish such facilities close enough to every community in Africa, especially in sub-Saharan Africa, in order to provide timely diagnostic testing for everyone, and especially among the poorest and most underserved communities. And so an ideal digital molecular diagnostics is a small electronic device providing a sample to answer solution to a diagnostic problem in a portable, easy to use, robust, and cheap format. And as you can see in the figure, any processing of a biological sample would ideally be integrated into the device before allowing quantitative detection of the molecules that provide the diagnosis. And the molecules detected may be nucleic acid, proteins, or small chemical molecules. A digital diagnostic will use lab-on-a-chip technology, and that's where we took the inspiration from for the design of this figure, with their defining feature being the generation, the processing, and the storage of data. So signals from the detection of analytes undergo analysis and processing within the device so that actionable results are reported to the user without the need for further analysis. Decision support to assist patient management can be integrated into the output from the device, and the results and recommendations, the recommended actions may be displayed as well on the device itself, or linked to the other interfaces such as smartphone, and the data generated by the device could be easily and immediately shared to facilitate patient care and contribute to disease surveillance. In the specific case of malaria, to do a specific example, a digital molecular diagnostic could detect a microscopic infection, detect drug resistance, integrate diagnosis and surveillance, and integrate diagnosis of other diseases. It can be multiplex and modular. But not only. We believe that the digital diagnostics have the potential to go well beyond simply filling the diagnostic gap. A German question is whether African healthcare system should recapitulate diagnostic models that have been developed in highly resourced health system, or whether they should take an alternative path. Achieving universal access to high-quality laboratory for all Africa by 2030 seems unrealistic, and therefore our approach, our project suggests an alternative which may encourage the diagnostics ecosystem in Africa to leapfrog over in global north and establish a more efficient and economical models of healthcare, bringing high quality precision medicine diagnostic to everybody, and mostly to the most marginalized communities in Africa. And if you are interested to know more about the technology we are developing, you can visit our website or contact me. And thank you. I'm ready for your questions.
Thank you very much, Francesca. What an ambitious and exciting project. So we are really delighted to hear about this and to find out more. I think there'll be a great opportunity to discuss all these digital and design approaches to infectious diseases and infectious disease detection, and also lots of opportunities there for data. And so I would like, before we take any more questions, to hand over to Alexandra for the last presentation of this session. Alexandra, we've been kind of very interested in following CIDEIM's work for a long time now, for many years, and I'm sure you'll give us some wonderful background on the project as we go along. But in the meantime, I'd like to hand over to you, and let's hear a bit more about the app that you've developed in context of cutaneous leishmaniasis. We actually, in fact, gave an award at this very same festival. It was, in fact, our very first festival back in 2017 for this wonderful app, but also incredible approach. So, Alexandra, I'll just give another moment for your slides to upload, and then we're ready to go and ready to hear more about your work.
Thanks a lot, Mariana. Hello, everyone. I'm going to starting with a video.
Este niño Junior hace más de 3 meses que está con la sospecha de leishmaniasis. Inició con una picadurita de un mosquito y se puso un puntico moradito y se fue avanzando. Al fin que dimos cuenta que fue leishmaniasis, ya ahí nos trajimos al hospital del corregimiento de Santa Cecilia, al puesto de salud. Ahí dimos cuenta que salió positivo el niño con leishmaniasis. Y de ahí luego pues iniciamos con el seguimiento del tratamiento al niño, ¿sí? Entonces nos tocaba trasladar de nuestra vereda a La Palmita aproximadamente 4 horas y media, llegar a la carretera, luego pues nos tocaba coger el chocho.
Cientos de personas con leishmaniasis cutánea que viven en zonas rurales dispersas de Colombia tienen acceso limitado a los servicios de salud debido a barreras geográficas, culturales y económicas. Esta combinación de circunstancias dificulta recibir un diagnóstico y tratamiento oportunos y, sobre todo, monitorear la adherencia y los resultados del tratamiento, ya que requiere varias visitas de control después de completarlo. La alternativa que usó CIDEIM para mitigar esta problemática es utilizar las aplicaciones móviles para realizar el seguimiento al tratamiento de la enfermedad. Estos datos que captura la aplicación y las fotos son subidas a una plataforma donde el médico las puede ver desde una zona alejada para determinar si el paciente curó o falló.
Pues a mí me pareció muy fácil, porque con un seguimiento que se hace, o sea, va de la mano todo, o sea, la misma aplicación usted le indica lo que usted tiene que hacer.
Si no hubiera podido, o sea, que me hicieran el seguimiento, me había tocado caminar más de 2 horas con ellos, casi 2 horas. Pues me quedaba duro porque la mayoría del camino es subiendo, es subida.
Esta aplicación es muy útil y es muy buena, y a nosotros en el programa de ETV de la Secretaría Departamental de Salud nos sirve para implementarla, seguirla implementando para hacer el seguimiento a los pacientes en el departamento, pues ya que es una zona donde aparecen muchos casos, e implementarla en otros municipios como Meistrato, donde se dan muchos casos de leishmaniasis.
A mí me parece muy bueno porque es mejor que el líder esté pues verificando cada 3 días, porque es que si no lo verifican, de pronto puede pasar alguna anomalía en el tratamiento al niño, entonces me parece muy bueno.
I want to share this experience of this app. This app was developed by CIDEIM and ISNTD University. We worked together to develop this project and develop this app. So CIDEIM is a research center. It is located in Cali, in Colombia. We were in the northwest of Latin America. And we were working with neglected tropical diseases. One of them is cutaneous leishmaniasis, which is a parasitic disease that manifests as a skin ulcers that you see in the pictures. Cutaneous leishmaniasis is a big problem in Latin America, and 55,000 cases were reported per year in 70 countries, and Colombia is the second most important country who have more cases in Americas after Brazil. And in the 2019, around 6,000 new cases occurs. And the most important thing is 82% of the cases occur in rural areas, which are located in really far from the health system, and the access to the center are really difficult. So the treatment is given for the government. We have 3 options. They are glucantime, miltefosine, and pentamidine, but the follow the patients is a challenge because we have to wait until 13 or 26 weeks after the starting to the treatment. So because the people live very far, it's really difficult to know what happened with the patients. To fill this gap, we developed the app. And the context we were working is a remote rural areas. We were working in Rovira and Pueblo Rico. those are small villages located in the Andean mountain, and the people who live there have limited access to health system. And the other important thing in the context is because we have a multicultural population, we have indigenous people, mestizo and Afro-descendants, and the cultural, they are totally different, and beliefs and practice regarding the health are totally different between them. But we have to face the challenge with the community, with the indigenous community, because we have barriers to communicate with them. And the other thing is they practice ancestral medicine, and we have to face this issue. Most of the people live in the extreme poverty and poor sanitary conditions. Half of the population affected in those areas were children. So the strategy, as I told you, that we designed was to do an app, but the most important thing is the app was operated by community health workers. So they were trained in many things, in leishmaniasis, clinical aspects, ethical issues, how to take the samples, and how to operate the app. And the idea is the community health workers identify the cases in the community. They applied a prediction rule. This is a rule that we designed to identify the possible cases of leishmaniasis, and those patients are referred to the health system to confirm the diagnosis. The health system confirmed the diagnosis and starting the treatment. And after, the patients goes again with the community health worker, and they starting to follow the treatment adherence, and they register the adherence to the treatment each day, and they register the adverse reaction. And at the same time, the community health workers take pictures in different moments, and in the beginning of the treatment, at the week 7, week 13, or week 26. And these photographs goes to a platform where the physician can see the picture and evaluate the clinical response. And this is the way that we know that the patient cure or no cure. So we developed this project in Pueblo Rico and Rovira, and we starting ongoing with this project, but we have some preliminary results. We recruit around 104 patients, and we found an important finding, because with this application, we compared our data with the patient followed with the app with the historical patients. So with the historical patients, 96% of the patients are lost, and the health system don't know what happened with them. They don't know if the patient cured or not cured. But with the app, only 12% of the patients are lost. So this is a good help for the health system to know what happened with the patients. So additionally, we found that around 22% of the patients don't cure, failure to the treatment. But when we see what happened in each study site, we found in Pueblo Rico, around 30% of the patients failure to the treatment, compared with Rovira that only 10% don't cure. So we were asking what happened, what is the difference between those places, what is the reason that the clinical response is totally different in each place. So because of the application, we know that the main drug used in Pueblo Rico is pentamidine, and because of pentamidine, 27% of the patient failure to the treatment. And the medication used in Rovira was glucantime, and only 10% of the patient failure to the treatment. So this is important information to the health system to rethink and reevaluate what is the best treatment options for the patients. Oh, I don't know what happened. Marianne, can you help me? Because the slides doesn't move. Okay.
It's okay?
Yeah, it's okay. So the other things the other information that we have because of this app is related with the treatment adherence, and with this application, we know 98% of the adherence of the treatment compared with the historical patients with only 8% of the treatments we can know the adherence. And this is really, really important information to the health system. But as I told you, we are still working in this project, and we have many challenges to solve, or maybe the audience give us some ideas to improve this project. So one of the challenges, we were working with a multidisciplinary team. We were working with social science, scientists, and health professionals, engineers, and community health workers. Some of them, it's the education is low, and another are more educated. So this is the thing is really, really different. And the other issue that we have to solve is the connectivity, because most of the people or most of the community health workers have to go to the top of the mountain, and because of those places have more, the signal is better. So we need to work more on it and to find the best option to improve the connectivity in those areas. And another challenge is to scaling up this application to health system. We started working with them since the project started, but we need to adapt this application to the health system and define their adoptions in the health system. Other challenge is translations of results in actions, because, for example, with pentamidine, it's easiest to the health system to use this medication because they only put the medications 3 or 4 times, compared with the glucantine that it's an intramuscular injections that need to put for 20 days. So we need to work with the health system to find the best options for the patients. And the other challenge is the sustainability of the interventions. Most of the community health workers are volunteers. They don't receive any payment to do this. Some of them are working with the health system, but not all. So we need to design a strategy to continue with the community engagement and to work in the sustainability of intervention. And finally, we need to design dissemination of results at different levels, since community to health system. The health system don't know yet the results, because we are working in the project at this moment. We didn't finish it, so we need to define how to disseminate this result in order to translation the results in actions. So thanks a lot to the research team in CIDEIM, Alexandra Maria del Castillo, who works day a day with this application, with Patricia and Jason, who are the people who are working in the rural areas with the indigenous people, with the communities, and Neil Alexander to help us to design the project and all the process, the data management team. This is a challenge to translate the data from the app to the results. Maria del Mar, who helped us in the design of the study. Caitlin, who was working together with the Sanofi people to do this video and help to transmit in the best way the information. Andres Navarro, Leonardo, and Domiciano. They are engineers, they are working in the CC University, and they design the apps together with CIDEIM. So the other is the community health workers. They did a fantastic job, the health authorities, and this project was sponsored by Sanofi, and really Sanofi give us many inputs to do the project, and they share their experience to develop this project. And thanks a lot to this event to share our experience in Colombia.
Well, I think I'd like to echo many of the comments in the chat, Alexandra. We are amazed and would like to thank you for this wonderful presentation and the huge opportunities afforded by such an app, not just for cutaneous leishmaniasis, of course, and some incredible work that's been done over the past 5 years, but with huge amounts of potential for most neglected tropical diseases, actually, in terms of patient engagement, treatment, supervision, follow-up, and so forth. So thank you so much for your presentation. Thank you, Francesca, as well, for kind of summarizing, again, a hugely ambitious project that is the one at the Digital Diagnostics for Africa Network. And so I know we've kind of reached sort of the time allocated for our webinar, but if you did have a few minutes, I think there's still quite a few questions and opportunities that the audience and ourselves we would like to unpack, if that's okay with you, if we've got a few more minutes.
Yes, of course.
Yes.
Yeah, great. Well, first of all, I'd like to say a quick hello in the audience. I was just going to get some questions, and I see that Alejandra Maria del Castillo is in the audience. So a huge hello, very warm welcome to the talk, and really enjoyed seeing your app in action in the film and in the presentation. You've had lots of thank yous and support from the chat across both projects. Just a quick question first, going back to the CIDEIM app. Karina Mondragon Shem, who's tuning in from Colombia, was saying, what a wonderful project. Great question here. Did you find any resistance from the communities? For example, people's suspicion of other purposes of the app in their phones? And I suppose that applies, of course, acutely to CIDEIM's app, but also in a broader sense, Francesca, perhaps this is something you're also having to think about, kind of the ethics behind digital diagnostics, issues such as privacy and data. So kind of opening up that question a little bit of resistance from communities or thinking really about data issues. What might be your thoughts on that? I'll go first to you, Alexandra.
Really, we don't have resistance from the community, but we are the scared to face them more than them to us. Because we had to face the challenge to the language and the beliefs. For example, in the beginning, the indigenous people think that the photograph stolen the spirit to them. Mm-hmm. So we have to start to share the app, how it's working, and we are working together with the social scientists in order to help us how to introduce the app. And the final, they feel comfortable using it, and it was novel for them, and they feel that it really helped to them to follow the patients. But I think the scare was more for our side than for their side.
Got it. That's a very interesting way to put it. And Francesca, what about yourself?
Yes. So you mentioned two aspects that are very important, and they refer also to different stakeholders. So on one side, we have the community we want, we are involved with, and so one of the first most important thing to assess is the acceptability of the technology, and not only the feasibility of in itself of the technology and technicalities. And we to facilitate these, we in Africa we identified an approach that can facilitate the uptake of technology, and it's the reuse approach. It's a reuse and improve approach, and it's a particular approach that accelerate, that basically is it consists of repurposing and enhancing existing technologies which are already familiar in the ecosystem in which the technology will operate. An example of this is the mobile phone in Africa. We know that mobile phones have modeled new ways of money transfer and support to healthcare, because people is, for example, M-Pesa in Kenya is a service to which that enables mobile phones owners to receive cash from relatives abroad, but also from donors, and so using something that's already familiar. It's a good strategy because it's not only decreasing the costs, but it's also leveraging on what is already there and accepted. So that is the one strategy. And the other related to the data instead. The data and the regulatory framework is something that is very much interesting for the commercial sector, because obviously the commercial sectors, the questions that an SME or industry would do to be involved in the project and invest into a technology would be if there is what is the competitor landscape, which are the advantages, are there incentives, or how is the regulatory framework, is enough stable, how the data will be used. So these are the kind of questions instead that are more on the commercial side sector. But also there is privacy and ethics also for patient data, of course, and that involves more security related to the technology and the network of the data, basically. But are very all very important questions and necessary stakeholders, and I would add to the stakeholders the local healthcare community workers, which are different from the patients and families, the higher level, the ministry and the policymakers. These are the. I actually wanted to do a question myself. So I would like to. You spoke about the challenges, and one of the questions was about that. So you partially replied to that. And one of my the question I'm interested is how did you select the community or the site to do the pilot and then for the technology, and how did you assess the acceptability and feasibility. But you already told that the community was very much positive and towards that.
So we select the sites. At the beginning, we were checking what's the needs, what is the places who has more cases. So Rovira and Pueblo Rico has a history with many cases. This is the first point. The second point is the stakeholders. So we were talking with the health authorities because we did other projects in Pueblo Rico several years ago. It was easiest to go into the communities. So the health authorities say yes, go. So some of the people who work in the health system joined with us to develop the project. So it helped us to join in this community. And the other thing we did the context analysis in order to identify the most important institution or organization in those places. So we found some institutions, and we were talking with these people and say them, okay, would you like to work with us, or this is the project, if you want, you are welcome. So this is the next step. And these organizations help us to identify the leaders in the community. For example, with the indigenous people, we work in the beginning, we have to talk with the gobernador. This is the main authority with the indigenous people, in order that he approved the project that starting work with us. And after we invite the people and show the project, that say, okay, if you like, you are welcome to work with us. We support you, we give the fund to follow the patient, you will receive the training, and this is your responsibility in the project, this is our responsibilities, and this is important for your community, this is a volunteer work, and if you want to join, you are welcome. This is the way that we did. And regarding your other questions, the usability and acceptability, I didn't mention this because we are still working on it. We don't have results yet, but we incorporate this evaluation. This is a qualitative component of this evaluation, but we didn't have the results yet. So we did this evaluation in 3 levels: in the health authorities and community health workers and patients, in order to know how is if this app is accepted, and how was the usability, because as I told you, the connectivity, for example, is a challenge. So maybe we don't know what they tell us about the usability, because this is really, really challenging in this area. But maybe soon we will have the results. We don't have the results yet, but we incorporate this evaluation in this project. Mm-hmm.
Thank you.
Mm-hmm.
That's fantastic. So we are coming up to the close of our session, and also the close of our first day here at ISNTD Festival. It's all about creative approaches to global health. And so I suppose my last question to you both, and also to conclude this day, is really to ask your opinion. So how important and how energizing, or how much has using this creative approach in the digital world, really thinking about the design of your scientific work, repurposing it in a different way, how much has that actually helped your work, and what are your next steps in that field? I know, Francesca, for example, you've actually worked quite closely with an artist to produce those beautiful diagrams. So how much did you both value the collaboration with the creative side, and what are your next steps? Is this something you want to pursue? Francesca, perhaps first.
Yes, so I was to say that it was a challenging work, because we have, as mentioned, we have tried to summarize the key point of a roadmap, and the roadmap is a very thick document of concept and methodology, so it was not really simple. But for sure, trying to translate the concept into the visual form helped to streamline the key messages, helped to highlight what was very important to communicate and to underline, and what instead maybe it could have been a little bit more in the back and less important, because probably the most challenging one is the last one, which is the one visualizing the entire roadmap. And I hope to have the opportunity to show it the whole work once it will be finished, because it makes much more sense. And obviously, trying to display the whole work in one figures is very challenging. But again, it helped us to understand which are the points that needs to be underlined and to focus on. So it helped a lot with the work of the whole team. And then I have to say that every point of view is needed, and every perspective and discipline is very much needed.
That's really good to know. And streamlining this process, not just for the artwork, but just in terms of your thinking, is probably also a gateway to facilitating the participation of new partners or whichever collaborations you might need in future. So it's a very important exercise. And what about yourself, Alexandra? How have you found it?
This is a good question. Most of the time I was working on research as a scientific group. And the problem with the scientific people is doesn't know how to transmit the knowledge and results of research. So work with people, to more creative people, helps to go into the communities, to go to the people. For example, Andres Navarro is here, I think so. Andres Navarro was the engineer who was working in the design, in the app, but in his team work, he involved a designer to develop the app, in order that in a simple way, the community health workers can fill all the information in the apps. And it's really important to have people to know how to work more easy with the communities, because for example, for scientific people, this is not our ability. So maybe, Andres, if you are here, can you explain us how was the process to design the app?
And Andres, if you want to come and explain, you could click the hand signal, the one that says request to speak. We could always, someone volunteered. It is Andres. Okay, so I will accept you, and I hope that with technology on our side, technology has to be on our side. We're the digital session, so this has to work. Andres will be on screen soon. And perhaps just while we wait for Andres to connect, and just to finish off, just wondering whether in both your approaches, that was related to a question that was on the chat, whether you're thinking of having a little bit of space to have not just quantitative data, but also more qualitative data. And Andres is here.
Yes. It's a bit complex, the process to enter to the room, but
absolutely. But the experts are here, so
yes. Basically, we have a team that includes visual designers. So the engineers work with visual designers that design the interfaces and make the hypothesis about the people, what kind of things the people can accept or not. And with that, the designers give to us a proposal for the interface design. We implement the design and then we test with the community leaders. That's basically that is the process. And until now, have been working well. The changes have been very, very few, and the acceptance until now have been very good.
That's great, and great to hear that there have been actually very few changes, because that would have been my question. Sort of, was your vision pretty accurate in terms of acceptance? And it sounds like from the onset, the design of your app was very well thought through and really matching to the communities that you are trying to involve. So that's one
of the main ideas was to avoid text, to use very, very few text and mainly use images, because indigenous people have their own language. Many of them speaks few Spanish, and of course they, in many cases, that they don't have a very good reading skills. So that was one of the main considerations in the design.
Fantastic. And I suppose that would be a lot easier to transpose if other groups were interested in such an approach across diseases, across regions. So anyway, thank you so much for sharing your approaches today. It was a pleasure to have our surprise guest, Andres. That was a great call. We should have had you on right from the start, shouldn't we? And Alexandra, thank you so much. Francesca as well. We'll definitely be keeping an eye on this space. James has left now, but again, another very promising digital approach with huge potential to underpin global health programs and really reach those elimination goals as outlined by WHO, whether in specific neglected tropical disease or more broadly and generally within the Sustainable Development Goal framework. So we're going to end our first day of the festival here with yourself, with the future. And I'd like to thank you all very much. I'm sure the attendees will join me in thanking you as well. I just want to remind everyone to tune in tomorrow for day 2. So today we've explored a lot of very broad and fundamental issues about the cooperation and the collaboration between the creative industries and global health. And tomorrow we'll be delving in a bit more detail and seeing a lot of very concrete examples, all the way from using ethnographic film to underpin public health research, all the way to the use of comics and participatory photography and so forth. So lots and lots of exciting material for tomorrow. But for today, again, a huge thank you, Francesca, huge thank you, Alexandra, huge thank you, Andres, and a very, very big thank you to all our audience who tuned in for today. And we'll see you very soon and hopefully see you tomorrow as well.
Thank you so much.
Thank you, everybody.
Thank you so much, Marianne.
Thank you. Bye-bye.
Bye-bye.
Session. Take care.
Bye-bye.
Bye-bye.